Right, now just very minor recap. Yesterday, our main focus, having introduced the idea of looking at cost per QALY as information that might be useful to influence decision making, our main focus after introducing the principle of it was to look at one of the key building blocks, and that is trying to understand how much time patients will spend in different health states and how that will change as a consequence of treatment. Because those changes in the amount of time patients spend in different health states is a main driver of our QALYs, or quality adjusted life years. But having established, or at least talked about, the different approaches to predicting how much time patients will spend in different health states, the next step is how are we going to value that time? How much benefit do we get from patients spending more time in a better health state rather than less time in a poorer health state? How much benefit? And so that's what I'm going to talk about this morning. I'm going to look at valuing time spent in different health states. In the afternoon, I'm going to look at a completely different, alternative set of approaches where we look at using money to value outcomes. And also we'll look at life satisfaction and well-being as a potential measure of benefit. But for this morning, I'm sticking with, as it were, what's become the conventional approach. And so another way of looking at this is how do we put the QA, the quality adjusted, into QALYs, the quality adjusted life year. Now you might wonder where this photograph comes from, or you might know. If you visit Tokyo Tower, there's a temple just beside Tokyo Tower. And if you walk by the back of it, you can look at these characters from behind. Now, as soon as I saw them, this suggests strange ways how my brain works, but as soon as I saw them, I thought, this is just like measuring QALYs, quality adjusted life years. We have a whole series of different measures available to us, but they're all kind of the same. So if you look at these individuals, they're really the same, but they're all a bit different from each other. They might be holding something different. Some have got a woolly hat on, some have something wrapped around their shoulder. So in a way, they're all just the same thing, but they're all a bit different, a bit individualized. Well, as we'll find in looking at how we put the QA into QALYs, the different measures available to us are really very similar, but different in distinct ways. So that's what will come out as we move through this. Okay, what I'm going to cover in this morning's lecture, I'm going to start with something called generic preference-based measures. And these are the mainstay of economic evaluation of healthcare. The generic is important because, in principle, if the measure's generic, we can use it widely across very differing areas of healthcare. And that's important because potentially it allows us to make comparative statements about the benefit we can generate by spending more on treating one form of cancer or more on investing in improved mental health services or more on respiratory care or whatever. So the generic bit's quite important. But the preference-based element is also very important. It stems really, I think, from a broader tradition in economics that sees individuals as the best judges, generally, of their own welfare. And so in economics, there's quite a strong tradition that individuals should determine what's important to them rather than some expert or some external body saying, this is what matters to you. And so for that reason, as these measures have been developed over time and economists have been heavily involved, there's been this focus on preferences. So what determines health is different for different people. We can't, the suggestion is, we can't define health in some absolute way. It's different for different people. For example, in my case, a really important part of health for me is being able to be physically active. Now, actually, I can't be super active because I've got some health problems, but at least I'm not just sort of stuck in a chair. Now, other people, that might not be very important at all. Maybe the real most important thing is absence of pain or something like that. And that's fine. Different people have different things they value. And so given that recognition, health economists have built into their measures preferences, rather than, for example, some expert judgment. In the second phase of the lecture, I'm going to look at how we measure these preferences, or how we, in the jargon, elicit people's health state preferences. And I'm going to spend a bit of time particularly on something called time trade-off. Time trade-off, which obviously gets abbreviated to TTO. There are other approaches, and I'll mention them, but I won't go into so much detail. Then I'm going to spend quite a lot of time on one particular measure, the EQ5D. EQ stands for EuroQAL, which in itself stands, I suppose, for European quality of life. And the 5D stands for 5 dimensions. And I'm going to focus on that one because it's probably, well, in fact, definitely, the most widely used generic preference-based measure in the world. I'm then going to close the lecture on an alternative approach. If you don't have access to EQ5D data, how might you use some other sort of health outcome data in order to generate your QALYs? And one approach is mapping. And in mapping, you're going from one particular measure, you're mapping it, you're translating it into, for example, EQ5Ds.